Welcome to day 29. Today's question was a 3-year-old child brought by his mother for complaint of abdominal mass noted during bathing. So the important symptom is an asymptomatic abdominal mass. Histopath picture is given to you. The correct answer is Wilms tumor. Wilms tumor, as we know, is the most common primary renal tumor of childhood. It is the fourth most common pediatric malignancy. Peak incidence is between 2 to 5 years of age and 95% occur before 10 years of age. Approximately 5 to 10% involve both kidneys either synchronously or metachronously. Risk of Wilms tumor is increased with 3 congenital patterns. The first group of patients have WAGR syndrome, that is characterized by Wilms tumor, aniridia, genitourinary anomalies and mental retardation. These individuals, they carry constitutional deletions of chromosome 11p. The studies on these patients led to the identification of the WT1 gene and PAX6 gene. Presence of germline WT1 deletions represents the first hit, and a nonsense or frame shift mutation in the second WT1 gene allele, which is called the second hit, results in the development of Wilms tumor. Second group of patients, they have the Dennis-Dash syndrome characterized by gonadal dysgenesis, early onset nephropathy leading to renal failure, and the characteristic glomerular lesion in these patients is diffuse mesangial sclerosis. These patients also demonstrate WT1 abnormalities. The genetic abnormality is a dominant negative missense mutation in the WT1 protein. Wilms tumor in the Dennis-Dash syndrome demonstrate biallelic inactivation of WT1. Also in patients को दूसरे germ cell tumors like gonadoblastoma होने के भी chances रहते हैं. Third group of patients is the BWS, that is Beckwith-Wiedemann syndrome, which is characterized by organomegaly, macroglossia, hemihypertrophy and adrenal cytomegaly, that is abnormal large cells in the adrenal cortex. The chromosomal region implicated in Beckwith-Wiedemann syndrome is localized to chromosome 11p, so-called WT2 locus, which is distal to the WT1 locus. Now, sporadic tumors, which account for 90% of overall tumors. Morphology: Wilms tumor presents as a large, solitary, well-circumscribed mass. The cut surface is soft, homogeneous and tan grey. Now this is how the picture looks like. You can see the tumor in the lower pole of the kidney and the cut surface is characteristically tan grey and it is well circumscribed. You can appreciate that. Microscopically, it is characterized by 3 patterns or 3 combinations of cells: blastemal cells, stromal cells and epithelial cells. 3 पैटर्न्स रहते हैं. majority of the cases में हमको 1 या 2 पैटर्न्स देखने को मिलते हैं. blastemal cells होते हैं, they are sheets of small blue cells. epithelial पैटर्न या epithelial component होता है, abortive tubules और glomeruli दिखते हैं उसमें. और जो stromal component होता है, that is represented by the fibroblastic or myxoid or skeletal differentiation can also be seen. 5% ट्यूमर्स में हमको एनाप्लेजिया देखने को मिल सकता है, दैट इज लार्ज हाइपरक्रोमैटिक प्लियोमॉर्फिक न्यूक्लियाई एंड इट कोरिलेट्स विद TP53 म्यूटेशंस एंड nephrogenic crest are considered to be the putative precursor lesions of Wilms tumor. पिक्चर में आप देख सकते हैं माइक्रोस्कोपिकली जो फर्स्ट पिक्चर है उसमें हमको अबॉर्टिव ग्लोमेरुलाई मिल रहे हैं, अबॉर्टिव ट्यूब्यूल्स दिख रहे हैं और शीट्स ऑफ स्मॉल ब्लू सेल्स. सेकेंड पिक्चर में एक अबनॉर्मल माइटोटिक फिगर दिख रहा है. क्लिनिकली इट प्रेजेंट्स एज अ लार्ज अब्डोमिनल मास, एसिम्प्टोमेटिक रहता है, लेकिन कभी कभी हीमेचूरिया, पेन इन अब्डोमेन या इंटेस्टाइनल ऑब्स्ट्रक्शन से भी प्रेजेंट कर सकता है। प्रोग्नोसिस में एनाप्लास्टिक हिस्टोलॉजी इज द मोस्ट क्रिटिकल डिटर्मिनेंट ऑफ एडवर्स प्रोग्नोसिस, and loss of heterogeneity of chromosome 1p and 16 is associated with a bad prognosis. Now sometimes radiation therapy itself may lead to development of a secondary primary tumor. Now the differential diagnosis include RCC, metanephric adenoma, mesoblastic nephroma, synovial sarcoma. DD for pure blastemal type tumor is all small round blue cell tumors. So please read Wilms tumor nicely. Thank you so much.